Bismillah ar-Rahman ar-Rahim. Dr. Othmane, do you hear me well? Dr. Othmane, please. Okay, do you hear me well?
Yes, I hear you.
Yes, thank you. بسم الله الرحمن الرحيم. اهلا بحضراتكم في DIDC. انا محمد عبد الحميد، مدرس مساعد في قسم الجراحه في جامعه الدلتا. انا سيشن هوست للفتره من 2:30 ل 5:10، واسمحوا لي اتكلم بالانجلش عشان انا Arab speakers. Welcome for all of you at the DIDC. محمد عبد الحميد, assistant professor at Oral Department, Faculty of Dental Medicine, Delta University. Today we have 4 sessions, starting with Dr. Othmane Bachir. Professor Othmane has a mastership in laser dentistry at University in Spain. He's talking to us about new trends in guided implant surgery, accuracy, predictability, and workflow. Dr. Othmane, you hear me well? Raise your hand, please. Thank you. Dr. Othmane, you have the time. You have 30 minutes, excuse me, from right now. And the mic is yours. Please advance.
Excuse me, can I share my screen now?
Yeah.
Perfect.
I'm letting
It's okay.
As per confidentiality, I have taken your acceptance for recording this session. Is it okay for you?
Yes.
Thank you.
It's okay. Can I start?
Yes, you can start.
Okay, perfect. Assalamu alaikum, everybody. I am very glad now and today to be with my friends, especially in Egypt. It's an honor for me. It's very difficult for me to share with you my knowledge in 30 minutes, but I will try to do it. I will talk about guided surgery. As you know, guided surgery is a huge topic, and it's very interesting for our daily practice, especially for implantologists. As you know, implant dentistry is prosthetically with surgical components. Practitioner must place implants ideally for prosthetic. Excuse me.
Excuse me. Sorry for interruption. Did you click on share content for sharing your PowerPoint?
Yes, I share you. You don't see my PowerPoint?
No.
Okay. Okay.
Take your time.
Yes. 1 second.
Okay. From the 3 points of sharing a content, please click it. I see well. We don't see your PowerPoint presentation.
It's okay? It's okay now?
Yes. Perfect. Please go ahead. Thank you. And sorry for interruption.
It's okay? Okay.
Yes, doctor. Perfect.
Perfect. As I said, implant dentistry is a prosthetically driven discipline with surgical components. Practitioner must place ideally implants using different kinds of guided surgery in order to have the best prosthetic outcomes. Sometimes no-size guides are used by experienced implantologists, but many would agree that the use of surgical guides will be more conservative and efficient approach to implant placement. As you see here, you can place your implant safely, ideally, in a critical zone the anterior zone, you can load, and as you see at the X-ray here, the perfect parallelism of the implant and also the perfect adaptation of the abutment to the crown. And when you check on the stone with the guide, you see the perfect adaptation of the crown. This is the planification and the X-ray after the surgery. As you see, the perfect parallelism, the respect of the bundle bone. When you go through the literature, here this consensus of the work group in 2018 with the serious guys, the most important factor of recession of the peri-implant mucosa is the malpositioning of implants. Of course, we have another problems like the lack of keratinoid tissue, lack of buccal bone, thin soft tissue, and surgical trauma. But the most important is due to the vocal position of the fixture. We have also the thin tissue by type, the lack of keratinoid tissue, and other factors like poor oral hygiene and systemic disease. This is the dramatic position. It's not accepted now. When we see this dramatic position here, like this position of the implant off axis, this big cantilever, this graph, this position of implant through the apex of neighboring tooth, this is very, very dramatic. There is also a serious study of Ontansquarian's team talking about the soft tissue and the complication. As you see at the top of the picture, we can accept this situation because we have a lack of soft tissue, but at the bottom of this picture, this is a dramatic position due to a too buccal position of the implant. Sometimes we should put some questions before starting any debate regarding this position of implant. Is it a no healthy patient or dramatic implant position and tissue handline? Or like this in this situation, is it a healthy young no smoking patient or excellent tissue handline and perfect implant positioning? Or is it a healthy keratinoid tissue or a good soft tissue management or perfect implant positioning? If you look this picture or this X-ray, is it excellent lab technician or a very easy case because of the perfect parallelism of implants? The accuracy of dental implant placement is a real challenge. This challenge maybe is often related to the operator skill, either in implantology, endodoncy, or prosthetics. The 3D position and the medial distal position, like here, as you see, maybe if you want to restore these two implants, you should remove this natural tooth. And the buccal angular undulation also is very important. The vertical depth, how we can control the vertical depth. If you want to achieve freehand surgery, it's not possible. It's completely impossible. The side condition, maybe sometimes you have a lack of space between the roots of standard diameters of implants. The root convergence, the bony defect, the concavities, the soft tissue concerns, the emergence profile. Let me introduce you the first case. This is a young woman, 24 I mean, with this Maryland bridge. She wants to remove this Maryland bridge and to place two implants in the lateral incisor. The challenge here is very, very important. Why? Because we are in the critical zone. This is the most difficult zone in implantology, the anterior zone in the upper row. If we want to place this implant, we should consider, before starting this surgery, maybe how we can achieve this surgery. Flapless, flap, which flap design, supracrystal incision, vertical incision, horizontal incision, many questions. And also the papilla. If we release the flap here in this case, maybe we will lose the papilla between the teeth, for sure. Like here. This is the planification with this kind of guide. This is the day of surgery. As you see here, we can put the implant, we can manage also the soft tissue. With this kind of guide, we have an open guide that allows us to achieve, as you know before, an immediate placement and immediate loading with the guide in place. As you see the X-side after the surgery, the perfect parallelism, the space between the roots, this is after the surgery. We check the accuracy of the guide. This is the immediate loading with the provisional. We manage also the soft tissue. This is the healing 10 days after. You can appreciate the good healing of the soft tissue, and this is the final restoration of this case. As you see, we don't lose the papilla, and we have a very, very nice prosthetic result. Sometimes how we can transfer all this information when we want to perform this surgery. DIDC started in 2000, and now we are in 2020 with these guides. Philip de Moyer is is an engineer from Brussels, Belgium, and with the advance of the 3D printing, now we move from this sleeve guide to the resin guide. It's very easy to use and it's very interesting. The first publication was done by Professor Jafar Mouhi and Maurice Albert Salama about this guide. It's open access. You can find it in the web, talking about this novel generation of the guide. To do guide-assisted surgery, you need three things. You need, of course, a patient. You need the CBCT, and you need a model, either stone or virtual. But the first step to consider before starting the surgery is to be certain that the patient is not only a candidate for guided implants, but for implants in general. We need, of course, a prosthetic project. Why? Because implant dentistry is a prosthetic-driven discipline. We need the implant planning, and we need the guide. This is the validation of the prosthetic project. It's very important with the patient. And we need just one surgical kit and one quadrangle, and that's it. You don't need to buy anything else. You can use your own tools and your own tools with your implant brand. You are not, it's not mandatory to change to your implant brand. There is a lot of advantages with this guide comparing to another guide. It's adaptable to all brands of implant, as I said. It's not specific to one brand of implant. The visibility is very, very important, and the accessibility is very important. The accessibility allows you to achieve a lot of procedures during the surgery, like the GBR, like raising the flap, without removing the guide from the mouth of the patient. You can also grab the finish from the crest, as you see here. You can release the flap just on the top of the crest. This is the final of the surgery. As I said before, you can grab the sinus from the crest. You can use your tools as the osteotomes. We then compare it to another guide like closed guide. You cannot use your osteotom, for example. But in this case, you can use your osteotom without removing this kind of guide. As you see here, the graft and immediately the implant placement. We don't need a lot of space. We need almost 30 millimeters of occlusal space, comparing to another guide. The only one that includes the depth control and allows an instrument in one hand. You don't have to buy any additional instruments. You can achieve a lot of procedures during the surgery, like the irrigation. The irrigation is very, very important. It's the only guide that permits you the irrigation of the implant side, comparing the traditional guides. The implant placement, that this guide allows the use of bone condenser also. You can place either conical or straight implants safely. You can also work in narrow space between the roots. You can achieve also a guided sinus lift. And you can also, this is the most important thing, immediately load the implant. Why? Because we will use with our laboratory or the lab technician the same guide, and in the laboratory you can achieve the surgery exactly the same way as you will do it in the clinic. I will see you how. This is in the laboratory. This is the stone. This is the model. We will use the same guide. We put the guide on the stone. We use the same quadrangle, the same drills. This is the final drills of your surgery. You will drill in the stone. As you see, the lab technician respects the same protocol as in the clinic. We will place the final drills and also the analog, and we will fix it like that. As you see, for the first implant, we will do the same for the other implants. We place the abutment. This is 4 abutments, 4 implants. We screw it. And we place our temporary bridge. As you see, it's perfect. And now the surgery is ready, and we can immediately occur in our office. We have four cases. We have the case for partial indentation, we have the case A and B. For total indentation, we have the case C and D. We don't have enough time to detail this. Maybe if I am lucky, I will come back for more details if you want. And after we have three steps, we have the DECAM or the STR file, the planning, and the twin guide order, and after you can program your guided surgery. With the advance of 3D printing, as I said before, we are now using a novel generation of guide with resin, and now it's patented until 2032. What we need just control angle, and that's it. Doing guided surgery is not a shame. It's a sign of responsible thinking. I will share with you some clinical cases because we have just 30 minutes to share my experience with you. I choose three cases. Now we will talk about partial Edentulous. We have 4 incisors to replace. Maybe we can choose 4 implants or 2 implants. We will start with 4 implants. This is how we can achieve this surgery. It's very easy and it's very accurate. And we can immediately load. The 4 incisors. This is the guide in place. The implant. The deep control is very, very important. This is the bridge. Immediately after the surgery, we check the occlusion. This is before, this is after, the X-ray. As you see, the deep control, the parallelism, the respect parallelism, the respect of the neighbor tooth, it's a perfect position of implant. This is before and this is after. In this case, we change the strategy. We can put just 2 implants in the lateral position. You can appreciate the perfect position of the implant and the palatal side of the maxilla. The same on the left side. You can appreciate also the accuracy. This is after the surgery. Now we can graft also. We can put our conical abutment, as you see here. You can add some resin or some composite. This is parallel, as you see in the video.
Five minutes.
Perfect. And this is the adaptation of the bridge. You can also graft. You can use PRF and check the occlusion. Some finishing. This is before. This is planification. The guide in place. This is 30 days after. This is the healing. You can appreciate the healing. This is the final bridge. 3 months later, you can appreciate the healing and the pontic and the implant. This is before and after. And you can appreciate the papilla and the final results. This is my light case. This is BMAX total rehabilitation. The same. This is the bloodless surgery in the laboratory with the guide. This is the provisional. And this is the surgery. We can place all the implants. Sorry. Our first implant. Sorry. Some technical complication. This is the computer.
No problem. Take your time.
Yes. This is my light case.
Yeah.
I try to respect the time.
Yes, thank you. You're good. You're doing great.
It's not so easy to treat this subject in 30 minutes. Maybe I will be lucky if
30 days.
Next time, inshallah. Next time. Or maybe in directly there in Cairo.
Okay, it's our pleasure.
One second, maybe we will have some technical complication of the video. Sorry for this.
No problem.
Yeah. But it's my last case. I have just 3 or 4 slides to share with you. And that's it. As I said, it's very, very clever and smart surgical guide because it allows us the surgeon to use the own tools. It means that you don't have to buy any additional tools. You have just to adapt your tools to this guide, and that's it. Versus the traditional tool, the guides, surgical guides, you should buy specific tools if you want to move from the freehand to the surgical guide.
It's quite easy, Dr. Othmane. We are very sorry we have to end the session right now.
Yes, if you want to name, I'm so sorry because I have 2-3 slides left, but it's not a problem. I can.
Okay, if you can
close the session if you want.
No, I don't want to do it. If you can restart the PowerPoint presentation, close it and open it again. Hopefully it will work.
Okay, 1 second.
Okay.
Okay.
Yes, now we see your desktop.
Yes. I have just
Okay.
2 slides with you and believe me.
Okay.
Okay. It's okay?
Yes, Prof, this is
It's okay? You can see my PowerPoint?
yes, I see two arches, upper and lower arch.
Yes, and this is the final result. This is the X-ray just immediately after the surgery, and this is the result, the immediate loading, and that's it. What I can see that the simplicity is the ultimate sophistication. That's why now the surgical guide should be used also by the experienced implantologists also, in order to have the most efficient and the most conservative approach for our daily practice in implantology. This is my last slide. This is XIMIR Square. It's one of the most famous square in the world. Now it's empty. It's not like that. I hope one day I will receive you here, and thank you very much for the invitation. Thank you very much for this short time. I am very, very glad to be with you. Thank you very much.
Thanks a lot, Professor Othmane Bachir. We are very glad for your invitation.
Thank you very much.
You accepted it in the rush of your schedule, and we appreciate it very well. Please, if you don't mind, we have a few questions from our audience. Do you mind?
Sure.
Okay, one of our audience, Dr. Rumaysa, she asks about the steps of surgical stents.
You can repeat? I don't hear. Excuse me, sorry.
Again, one of our audience, Dr. Rumaysa,
yeah,
about the steps of surgical stents.
Yes, we have 3 major steps. You should have a prosthetic project, and you should validate the project with the patient, 1 STL file, and 1 DICOM file. And after, you can send everything to the twin guide laboratory, and after they will send you the project, and after validation, you have the 3D printing, and that's it. You have 3 steps. It's not so complicated. It's very, very easy.
Yes, great. On behalf of the DIDC organizing committee, we would like to thank you.
Thank you very much.
This outstanding lecture. Hopefully, we can meet again in a real-time conference after this pandemic would end, inshallah.
Thank you very much. Thank you very much.
Thanks a lot, Dr. Othmane.
Thank you. Bye-bye. مع السلامة.
مع السلامة. For our audience, inshallah, we will start sharp at 3:15 p.m. With Dr. Bailil Merawi from Italy. Inshallah, you can have a 5 minutes rest or a 7 minutes rest, I think, and meet you again. See you.
See you. Bye.